Okay. My whole purpose is I want you guys to just understand how the immune system works during these different processes, whether it's an autoimmune disorder, HIV, which is kind of in a category of its own, but whether it's an autoimmune disorder, whether it's a result of an infection, whether it's an allergy, just if you understand the underlying immune process and what's going on, understanding humoral immunity has to do with antibodies and the B lymphocytes versus cell-mediated immunity has to do with the T helper cells and the T killer cells, and that is more having to do with phagocytosis and just killing off the disease or whatever the invasion is. So we're not going to go through every single possible infection in life because we could be here till the end of the year. But what we are going to talk about is just what happens when a person has an infection. As we go on and learn different body systems, we will learn different inflammatory processes. You will hear again about different autoimmune disorders and different infections. But I'm not going to teach you all of that all at one time. If you understand the concept of an autoimmune disease, like I said, for most of them, the treatment is exactly the same. It's just suppressing the immune system. Infection is just about identifying what caused the infection and treating it or preventing infections. So hopefully in fundamentals, you learned about the chain of infection, but if not, we're going to learn about it now. The chain of infection, it includes, you have your infectious agent, whether it's a bacteria, a parasite, virus, whatever, you have this infectious agent. It lives in its reservoir. So depend on, okay, like fungi, like warm, moist, heated places. Giardia, you may find Giardia in water, right? That's something that people usually get passed through water. So that is just where that natural habitat of the organism lives versus at the bottom, you see the susceptible host. The host is the person who gets infected. So the portal of exit is how that illness escapes. Like, for example, usually, especially in an adult, you don't really want to, you'll notice doctors don't really like giving antidiarrheal medication. Why? Because diarrhea is how a lot of viruses and bacteria escapes the body. So that is the portal of exit, the diarrhea versus the means of transmission. So is the diarrhea the exit point, but you got it through the fecal oral route, or was it contact, skin contact with someone else who had MRSA and now you caught that? Is it a droplet, like somebody coughed in the air and now the droplet infected you? That's the means of transmission. And then, of course, the portal of entry. Did you breathe it in? Did you eat something that had it in it? Did it go in your mouth? Did you not wash your hands and then ate with your hands and got it? So the whole point of infection control and infection prevention, like you see in the picture, is about breaking the chain somewhere. Oops, sorry. Breaking the chain somewhere, right? Whether it's interrupting the agent, you see it, hand hygiene. If you're washing your hands so you don't pass something on to somebody else, or are you taking your antibiotic so you don't pass something on? Whatever the case be, all along the chain, somewhere we're trying to break that chain so to stop the spread of infection. So when it comes to infection, you can have colonization. If any of you are LPNs and you work in a nursing home, you may be familiar with that. Like, you see these elderly people, every time you do a UA on them, it's bacteria in there every single time, right? If they've been on antibiotics, they still got that bacteria in there. Why? Because they're colonized. It just lives in there. At this point, it's just there. It's not doing any damage. They just happen to be colonized with whatever, E. coli. Same with MRSA. I'm pretty positive a lot of people working in healthcare, the more contact you have with these patients, I mean, it would be safe to say I probably am colonized with MRSA. Do I have a MRSA infection? No. I just happen to probably have MRSA living on my skin at all times. So there's a difference between being colonized and actually having an infection. An infection means you got this bacteria or whatever living in you, and now it's causing a reaction. It's causing a fever. It's causing whatever. So that's the difference. So when we talk about infectious disease, that means that it has caused symptoms and everything. It has caused a disruption in that person's wellness. Hold on one second. Okay. So with that, you know, that's how you see this. There's levels to this stuff, right? So stages of infection. Every disease is different. The incubation period, if you guys remember, if you took microbiology and biology before you got to nursing school, you may remember talking about this, the incubation period. Incubation period is different, like for COVID versus HIV. HIV has a long incubation period. That's why people don't have symptoms for a long time. People go undetected for a long time because the incubation period is long versus like, you know, people with COVID, I think they're starting to show symptoms within a week or whatever. I don't know. Again, COVID is not going to be on your NCLEX. I'll just keep bringing it up because it's going on right this moment. So there's that. The prodromal stage of an infection is when a person is most contagious. Hold on, sorry. So when they're most contagious, that's when the symptoms start, when they start to feel not good, still not quite sure what's wrong with them. That's actually when they're most contagious. And then when they're in the full stage of illness, they're having specific signs and symptoms of that illness. The convalescent period, that's when you've got those antibodies built up and now you're recovering from the infection. So with the COVID, they were giving people convalescent plasma infusions. Those were the antibodies of people who were recovering from having COVID. Different infectious agents. I didn't put parasites on here, but that's another infectious agent. Protozoa, another. So there's any type of infectious agent. Bacteria, if you remember from biology and microbiology, there are, you know, different shapes and appearances to bacteria when they look under the microscope. And they have different reactions to a gram stain. Are they gram positive? Are they gram negative? This is how we identify bacteria. And that is how we know which antibiotic and everything's going to work. With time, with experience, you will come to learn stuff like that. Like, say, you know, because initially when you do a culture, you get a preliminary result. It's not going to say right away MRSA, but it may say, all right, we have some, you have cocci, you have gram positive cocci in clusters. That's all it's going to say. Well, with experience and years of looking at these culture results and working side by side with doctors, you will grow to learn, like, okay, I see this preliminary, they got gram positive cocci, so I know it's probably a staphylococcus and it's in clusters. That could be MRSA. But as a nursing student, this is not microbiology class. As a nurse, you don't necessarily need to know that. But like I said, over time, you will grow to learn that. Just know different bacteria react differently with different medications. Aerobic versus anaerobes. Anaerobic infections are usually worse because those are infections, they don't even require oxygen. They just can reproduce and wreak havoc without even needing oxygen versus aerobic. Viruses, obviously the main thing you need to know, you're not going to use an antibiotic to treat a virus. Everybody wants to tell a story about when they had a virus and they took an antibiotic and they felt better. That is great. However, antibiotics do not treat bacteria. They may produce some effect, side effect, or something that made you feel better. They may kill off a co-infection you have going on that is bacterial, but antibiotics do not fight or attack viruses. So treatment for viruses is usually supportive. Drink lots of fluids, get plenty of rest. That's supportive care. Symptoms with viruses, a lot of them are pretty much the same causes, like those generalized symptoms, weakness, malaise, fatigue, a whole body ache, headache, red eyes. Fungi, we talked a little bit about it. Candidiasis. Candidiasis is a fungus that produces thrush. It produces those skin infections, and it produces, like under the breast here, and it produces vaginal yeast infections. It affects mucous membranes in the skin, versus like this other picture, that's ringworm. Ringworm is a tinea. Tinea is another fungus. You can have tinea capitis, tinea, which is ringworm on your head, tinea corporis, which is tinea on your body, ringworm on your body. You could have the kind of tinea crocurus, which is crabs, or jock itch, or not, whatever. Jock itch, where you have the tinea rash on your groin. Crabs is lice on your pubic hairs. But anyway, fungus would be like jock itch, athlete's foot. All that is caused by tinea. So most fungal infections you usually see will be tinea or candidiasis, but there are millions of other fungi. A lot of times fungi, again, is an opportunistic infection. Thrush, yeast infections, all that, usually opportunistic. Factors affecting susceptibility is going to be the same, for everything. Obviously, age. If you're really old, your immune system is slower than if you're a young, healthy adult. If you're a newborn baby, you barely have an immune system. So age is going to affect that, whether you had your vaccines or not, whether you have a normal pH level. For the ladies, you know this, like if your pH is off, if it's more basic, and we'll talk about acid base in a few weeks, but if it's more basic or alkalotic, it's going to promote reproduction of bacteria and stuff. Certain organisms live in an acidic environment. Certain organisms live in a basic environment. But anyway, that can affect it. Why do you think everybody's walking around drinking alkaline water and all this stuff? Different pHs affect different things. The number of organisms. Obviously, if you got 3 different infections, 3 different bacteria in your wound is going to be in much worse shape than just one organism. Virulence is like what we were talking about, the viral load, or how sick that other person or whatever you came in contact, how much of it did you come in contact with? That's why, like they say when people are getting treated for HIV and the viral load is, quote, undetected, what they really mean is those numbers are so low, but you still have HIV. So they say you cannot pass it on to your partner. However, I would never in life recommend anybody have unprotected sex knowingly with someone that has HIV, because there's always a chance that could be spread. But the idea is when their viral load is low, it's going to be a lot less likely to contract the disease. Fatigue, anything else. Obviously, if you have other conditions, that's going to affect your susceptibility, like diabetes or certain medications like steroids, lower your immune system. Signs and symptoms, I mean, we already know this. It's the same with inflammation, redness, heat, swelling, pain, loss of function. Oh God. Sorry, I'm traveling today, so people are asking me about picking me up from the airport. Okay. So you guys know this stuff. Remember the ESR, the erythrocyte sedimentation rate. That's going to be elevated because with infection comes inflammation. The whole process starts going on that we just talked about. And then, of course, you're going to see bacteria in the urine or the blood or wherever the heck it's coming from. So nosocomial infections. Nosocomial is a fancy name for hospital-acquired infections. Healthcare, really the term is healthcare-acquired infections, because you could be in a nursing home and it still falls under the same tier. So with that, types of healthcare-associated infections could be related to catheters, urinary catheters. If you work in a hospital, you might hear these terms. I mean, when you get into nursing, you'll definitely know these terms. CAUTI. CAUTI is talking about catheter-associated urinary tract infections. I've never heard SSI, but surgical site infection, but that was an abbreviation in Lippincott. But you will hear SCIP, which is a national push to prevent surgical infections. So every hospital has a SCIP protocol, meaning, okay, if they're getting this surgery, they're going to get this antibiotic prior to surgery. To prevent an infection, or if they just had this, they're going to get this antibiotic after surgery. Everybody has some procedure to prevent surgical site infections. CLABSI, when you work in the hospital, they are going to walk around every day. Your charge nurse is going to ask you, how many patients have a catheter? How many patients have a central line? And how many patients are on isolation? Why? Because the cost connected to hospital-acquired infections is so great. When a person acquires an infection that they did not come in the hospital with, insurance is not going to pay for that. Insurance is not going to pay for a hospital-acquired infection. Hence why many nursing homes, if any of you work in a nursing home, when a patient is admitted, the first thing they do on day one is a UA and culture. They're going to do a UA with a culture. Why? Because if that person comes up positive for an infection, they don't have to claim it. It didn't. They came here with this infection. They didn't catch it here. And is that why they already if they already tested positive? Okay, if a patient comes in with C. diff, again, they want to know that, because once that patient been there 24 hours, Jenny's asking, if you look in the chat, is that why they don't retest? Technically, if a person has C. diff, once the diarrhea has ceased, you don't have to retest. So even if they weren't living in a nursing home, if you're having formed stools, that's usually when they say you could come off isolation and stuff like that with C. diff. Because if you're not having diarrhea, you probably do not have C. diff. Yeah, family members will ask you to retest, but again, it's an unnecessary cost, and that's really at the discretion of the doctor. But this is why education is so good, because if you just explain to them if you have C. diff, it's like horrible diarrhea. It is going to make me incontinent if I had C. diff. C. diff isn't like, oh, I had some loose stool today. C. diff, I think one doctor told me, what did he tell me? To qualify for diarrhea is something like 3 to 5. Yep, peeing out of your butt. It is 3 to 5 watery episodes of diarrhea in an hour. Watery stool, I think it's like 3 or 5, something like that, in an hour is what qualifies as diarrhea. Me eating Taco Bell and then going to the bathroom one time after I ate Taco Bell, or maybe twice, 2 hours later, that's not diarrhea. Okay, you had a little upset stomach, you had a little loose stool, but that is certainly not considered diarrhea. So that's why they don't retest. But like on admission, we always, a lot of facilities do test right away because the hospital or the facility does not want to take responsibility for that, because once they get it, the hospital eats up the cost. So if that person gets a UTI after, say, the woman comes in for a DNC for whatever reason and stays overnight, I don't know, and she had a urinary catheter and she gets a UTI. If that UTI ends up making her septic and she ends up in the ICU and her hospital bill is like $30,000-$40,000, ain't nobody getting paid. Nobody is getting paid. Hospital is paying for her stay. What was somebody going to ask a question or say something? No? Okay. So anyway, so that is why and on top of, let me go back. First of all, we want to protect our patient first and foremost. We're nurses. We want to keep them safe. But as an organization, why your hospital cares is related to costs, okay? It costs millions of dollars every year to pay for hospital-acquired infections. So things that put people at risk, the immune, same thing that's going to put you at risk for everything. The other thing is, like we talked about with the opportunistic infections, is the prolonged antibiotic use and these really high-powered antibiotics like Vanco. Those medicines, because they're so strong, they kill off the good bacteria, the normal healthy flora in the intestinal, in the GI tract, and in the vagina. Antibiotic resistance. So MRSA and all these things, why does it happen? Mostly because we don't know how to use antibiotics appropriately. We do whatever we want. And here in America, we want a pill for any and everything. Give me a pill. Oh my God, my fingernail. Somebody yesterday, I will not name who, but an instructor at the school was asking me for medical advice for a painful fingernail. Okay, I mean, is it swollen? Is there pus coming out of it? Do you have a fever? It's a fingernail. Like, just, ice it, whatever. You don't need to go to the doctor every time your fingernail hurts. But this is like an American thing. That's what we do. We just, oh my God, my baby had a cough twice today. Let me take the baby to the doctor. Let me get an antibiotic. Oh my God, I got the flu. Give me an antibiotic. Everybody want an antibiotic for everything. Like I said before, antibiotics do not treat anything but bacteria. Every antibiotic is made to treat different bacteria. So when you're around here taking penicillin for what actually ended up being a MRSA infection, or you're taking, if the antibiotic doesn't match the bacteria, then it's going to become resistant. So using antibiotics inappropriately, that means the prescriber, the doctors. What happens as a provider is patients will pressure the hell out of you. They will come and they will tell you they need an antibiotic, and you will talk to your blue in the face. And you talk to your blue in the face, and they don't care. They didn't hear nothing. Just get, okay, but still, doc, you gonna give me a prescription? Because I'm sick. Like, nobody wants to just wait for things to run their course. not completing antibiotics as prescribed. How many people do that? Oh my God, my throat hurts. Let me get this antibiotic for strep throat. There's a reason why it was prescribed for 7 days. There's a reason why stuff is prescribed for 3 days. There's a reason why stuff is prescribed for take one a day versus one twice a day. Why? Because they have done enough experiments to figure out how long that medicine is going to stay in your system and how much of that medicine it's going to take to kill off that bacteria. And then wrong antibiotic. Like I say, you're taking the wrong antibiotic for the wrong infection. You around here taking some pills you had in the cabinet from that strep throat last month, but really you got gonorrhea. Not gonna work, okay? So methicillin resistant Staphylococcus aureus is exactly that. Staphylococcus aureus is a bacteria. I'm not a microbiologist, so I'm not about to get all into that, but it is resistant to methicillin, which was the precursor to penicillin. So basically, we have a staph infection that is resistant to all penicillins and many other antibiotics. So when that person who's colonized with MRSA gets a cut on their skin, or they get sick and their immune system is weakened, that's when MRSA comes in and attacks. So it complicates many hospitalized illnesses and procedures. VRE is another one, another antibiotic resistant infection. And it usually is found in urine or wounds. You don't usually see it elsewhere. It's usually found in wounds. And oh, see, look, Melissa, her parents just given her penicillin that they had in the cabinet, and now she's getting hives. She having a serious allergic reaction. Right? Everybody wants to be a doctor. Calm down, people. If you think you're that sick and you need an antibiotic, go see a doctor. But I also wouldn't run to the doctor. Like, I mean, I couldn't tell you how many times when I worked in the emergency room. Okay, and what's bringing you in today? I threw up. Alrighty, and how many times did you throw up? Once. Oh, okay. And when did you throw up? 20 minutes ago. Oh, okay. So never in life you've never had nausea before. You've never thrown up before. I mean, wait and see what happens. A lot of stuff, your body is resilient. I just told you all the great things the immune system does. Give your body a chance, because you're actually weakening your immune system by just running out and taking pills every time something ails you. Clostridium difficile, C. diff, the peeing out your butt disease, like you guys said. It is a spore forming bacteria. Spores are hard to kill. That is why you need to use bleach to clean those rooms, or you need to wash your hands with soap and water. C. diff is resistant to alcohol, which is in hand sanitizer. And it is, like I said, opportunistic. It is usually the result of people who have been, yep, exactly. Exactly what Kanisha said. If people really knew the costs associated with this, they would not run to the doctor for everything. But anyway, and not only that, you're hurting your body. But anyway, yes, so we already talked about C. diff. It's related to, you have good bacteria that lives in your digestive tract. You have good bacteria that lives on your skin. And you have good bacteria that lives in your like vagina and other mucous membranes, like in your mouth. When people say, oh, the human mouth has so much bacteria in it. Yes, it does. But it's not causing you any infection or harm. So when we kill off too much of it, then we get the opportunistic infections. So now you guys got to talk. How can you prevent nosocomial infections?
Hand hygiene.
Hand hygiene.
Yes, hand hygiene. What else?
Change catheters.
Yeah, knowing when to remove invasive catheters and things, exchanging them when they're supposed to be due. Like some people do require long-term Foley catheter, and that needs to be changed, every 30 days or whatever. It needs to be changed regularly. Isolation, Jenny put. Isolation, transmission-based precautions. Exactly. Use of PPE. These are all the ways we as nurses can prevent nosocomial infections. So hand hygiene, like you guys said, use of PPE, whether it's a glove, a gown, a goggle, whatever. Universal precautions and transmission-based precautions. We'll talk about that in a second. Decontaminating rooms, wiping down surfaces. Do you go in a room and grab one, you go in a room and grab equipment from one room and wheel it on into the next room? No, even an IV pole. If I'm taking something, we're in a hospital or a nursing home. If I'm taking something from one sick person's room to another sick person's room, I'm gonna wipe it down and go see the patient. I'm gonna wipe my stethoscope down with an alcohol pad before I put it on somebody. It's the equipment, it's us. When these infections, that's why you go to the hospital or a nursing home, you see 6 people on the same floor with C. diff. And like somebody just said, you go to work and take care of somebody, and 3 days later they're on isolation. Why? Because one of us passed it to them, or all of us collectively, not being mindful of infection control. Hurrying up and just wiping stuff down real quick and then just throwing the patient in a room. Not being mindful of infection control. And then the other piece is educating patients and their families. How do they prevent spread of infection at home? Moving on. You have universal precautions. Those are the precautions we take with any and everybody, especially after the AIDS epidemic, first hit the scene. Universal precautions is basically this. Universally, we are going to treat every patient as if they have an infectious disease. Right now it's COVID precautions. So now you're wearing a mask, all types of stuff, a mask, a face shield, a hazmat suit. But again, for the sake of learning right now and passing NCLEX, just try to block COVID and what you're doing at work right now out of your head. While it is important to know the COVID measures, obviously now in the hospitals and everything else, as of right now, by it being so new, it is not going to be on your NCLEX. So the normal universal precautions before COVID was, we just use it depends on what you're coming in contact with. Use hand hygiene, of course. Use gloves, especially if you're about to do something invasive or you might have the risk of coming in contact with bodily fluids. Gown, if you need it. If I'm going in and this person has a huge abdominal wound and it's 2 feet across by 1 foot across and it's going to be bleeding and all type of discharge coming from it, heck yeah, I'm putting on a gown. Shoot, putting on a hat, putting on some booties on my feet. I don't want that stuff on me. So it's basically just taking whatever precaution is needed to protect yourself and protect the patient. But it's not specific to any disease. This is just overall protection for everybody. So then you get into the disease specific, and that is the transmission-based precautions. Those are going to be an added addition on top of universal precautions. And maybe one day we will get back to just regular old precautions. But so airborne precautions, we're going to go through each one on the screen. So we'll go through that. But there's airborne, there's droplet, there's contact. And then on top of that, there's what? What's the other kind of isolation?
No, it's my tongue.
What'd you say? I'm sorry. Which one?
Is that Victor?
That. What did we talk about earlier? Precautions. Reverse, right? Protective. Neutropenic precautions. Neutropenic precautions. So that's going to be, even though you're not transmitting anything from you're not catching anything from the patient, but you're protecting them. And it's going to look the same. You're going to be wearing a mask and a gown to protect someone when they're on neutropenic precautions. So yeah. Oh, okay. The other thing to know, and pretty much if you guys work in healthcare, you know this, but if you're like me and you coming from the Olive Garden, you don't know this stuff. You must put that PPE on the moment right when you're going in the room. It does not matter what you're going in the room to do. So you better get everything done while you're in there. Like back in the day when I first started, actually, you could okay, if I'm just going in the room, like if I'm in dietary and I'm just coming to get your food order, trust me, I do not plan on even being close to you or touching you. So I don't need to put on any protective gear. That's how it used to be, unless they were on like airborne or droplet. Now you have to put everything on no matter what. So you done went in there, you did all your work, and now you left out and you're like, oh shoot, I forgot my pen. Well, get your gear on, because you got to go back in there and get your pen, or you better get you a new pen. But that is all I need you to know. If you are going in, and every hospital, every facility that has inpatients, they're going to have an infection control officer. It's going to be that stuck-up rude nurse usually. And if they see you in one of these rooms without your equipment, or even your manager, if your manager walks by, if the DON walk by, oh, they're going to rip you a new one. And you talking about, well, I left my pen in the room. They don't care. The rule is you put your gear on whenever you go in that patient's room. So airborne precautions, right? That's kind of like, I mean, well, with the N95 mask, that's why COVID to me is confusing. Like some people wearing N95, some people wearing surgical masks. The N95 mask, and I'm not talking about the China-made K95 because I never heard of that till last year. But the N95 mask is the one you have to be specially fitted for in the hospital. They are not one size fits all. And if you lose weight or gain weight, you may need to be refitted. I mean, I'm a woman in my 30s. My weight has fluctuated ever since I've been a nurse. I have gone back and forth from a small to a medium, when I lose weight, when I gain weight. So the N95 is going to be specially fitted. Airborne precautions is also going to require a negative pressure room. It is not considered airborne precaution. You're not doing airborne precautions if that same air is still sitting in the patient's room. The airborne precautions is what your thought is, that person just sitting there and breathing alone is spreading the disease, right? Their breath is spreading the disease. They don't need to cough. They don't need to sneeze. That's with droplet. They just got to be here in the room. So if them sitting here all day with the door closed, breathing in the room, and there's no negative air pressure is basically like a vent that is a vacuum. It's sucking the air out and blowing it outside, getting that air out of that room. It's constantly circulating the air in that room, because the air is infectious. So you need that thick N95 mask that is specially fitted to your face, because you don't want air slipping in there. Everybody got that? That would consider TB. Oh, the other thing I want to tell you about that, varicella. Varicella could be chickenpox or it could be shingles. Varicella is airborne precautions while the patient has open lesions. So when someone has shingles or when someone has chickenpox, they should be placed on both contact and airborne precautions. But I will be honest, I don't usually see them put in a negative air pressure room. I usually see it more like a droplet, and like you just wear a mask and a gown. But the thing is, that varicella can come out airborne from those lesions while they're open. Once they scab up and get crusted over, then you don't got to worry about airborne. Okay, almost done. Droplet precautions. That's, like I said, that's just the regular surgical mask. That's what we're all doing right now, every day for COVID. We're wearing a mask everywhere we go. That is to keep those droplets, keep your droplets to yourself, okay? Stay away from me. This thing says 3 feet. No, we done bumped it up to 6 feet. I need my space, stay away, cover your mouth, and I'm gonna wear a mask. Airborne precautions. Previously, the door has to stay closed at all times. Droplet precautions, you could open the door or whatever, it doesn't matter, but you don't want that patient really, you don't want them, they're confined to their room and you're wearing a surgical mask. I'm pretty sure everybody's familiar with contact precautions. That's when you put the gown on. So you wear a gown and gloves. MRSA, VRE, C. diff. These are all contact precautions. The other thing is knowing how to don and doff the protective gear. Don, I don't know why in healthcare everything always got to be so fancy. Don means put on, doff means take off, okay? So how to don, there is a procedure to this, okay? Like you may put your gloves on first, but you're going to take them off, what is it, last? I don't know. Let me not tell you the wrong thing, but there's a step-by-step how you're really supposed to take this stuff off. So read in your book, and I'm gonna post a handout on that, because don't ask me, I always get it mixed up. I'm always jacking stuff up. So I never work. If you work in surgery, you should be a pro at this stuff. But me, I only worked in surgery briefly, and I used to always get yelled at by the surgical techs. Yeah, gloves off first. There you go. See, y'all people know. See, I always take my gloves off last. I take them off last. I don't know why. But so read your book for that. Don't quote me. Oh, glove last and surgery. See there. Okay, I knew something. I'm like, I always thought it was gloves last until I read the book. And then it says gloves first. But okay. So you may get asked about that though. Know that. Donning and doffing PPE. All right. So now, what can happen with any infection? Any infection can lead to sepsis. While I'm not going to, this is not critical care. You guys are going to learn more about sepsis and shock next semester. But I don't want, I want you guys, by the time you get to next semester, it's almost like a review. You already heard this before. I also want you to understand, like if you're CNAs and or wherever you're working in healthcare already, this should give you a better understanding of what's going on. So with sepsis, like AIDS, is a syndrome. It is not a disease. Sepsis is a collection of symptoms and clinical manifestations, but it can happen with any type of infection. So I was just giving you these terms because they were in your book: bacteremia, fungemia, but any infection can go bloodborne. And what happens is when the infection gets out of control and it gets in that bloodstream, now it's traveling and it's affecting the whole body. And it's causing a system-wide inflammatory response. So remember, vasodilation. Vasal is causing a release of system-wide now, that histamine, that bradykinin, all that stuff is being released, And now you have system-wide vasodilation. That's what leads to severe sepsis and shock, is all your blood vessels are dilating at the same time. And now you are, at risk for death. Now you're facing life or death, okay? And that is why they give these people meds that are called vasopressors. If you work in the hospital, you may have heard that term, vasopressors. I don't expect you to know this for your test, but I do want you to understand that I do want you to know the basics, that any infection could cause sepsis. And sepsis, just like anaphylaxis, is a system-wide inflammatory response. So when that histamine and all that stuff is being produced locally, you may have localized swelling. You may have localized hives. But when the bacteria is spread throughout the body and it's being released all over the body, now you have system-wide vasodilation, and now you have organ failure. It is leading to multiple organ dysfunction, which they call MODS, and just it's wreaking havoc on your entire body. To qualify for sepsis, you must have an infection, a known infection, and 2 of the SIRS criteria, these things listed below. SIRS criteria, system inflammatory response syndrome, which basically is sepsis. 2 criteria would include evidence of a fever and an elevated heart rate, greater than 100, elevated respiratory rate and an elevated heart rate. Any type of evidence of organ dysfunction. So say they have a fever and their BUN and creatinine is elevated and they have an infection. We know they have an infection, they have a fever, and they have organ dysfunction, they're septic. We know they have an infection, we know they have a fever, their white blood cells is greater than 12, they're septic. Does that mean they have severe sepsis and they need to be in ICU? No. Does it mean they need vasopressors and they're going into shock? No. But what it does mean is if you don't recognize the urgency now, they will go into shock and die. So if you work in a nursing home, oh my God, it seemed like everybody got sepsis because of the way elderly people, their immune system is weak. And the other thing about them is their temperature tends to be lower, remember? So they don't have initially a fever. Or if they have dementia and they can't verbalize that they're sick. So that's why a lot of these patients in the nursing home end up there, by the time they get to the hospital, they are in sepsis. Now, you could be on a regular floor with sepsis. Like, I mean, if my blood pressure is 100/20, I'm alert, I'm oriented ×3, I'm, otherwise fine. But I have pneumonia, I have an elevated heart rate, and I have a fever. Technically, I am septic. However, the problem is in healthcare, we usually don't recognize sepsis until it's at that severe sepsis. A student yesterday told us a story about how her uncle went to the ER with the flu. Her uncle was 40-some years old. He was healthy. He was a runner. So he went. They told him he had the flu. And, whatever. Told him drink plenty of fluids, get rest. He went home and came back the next day in septic shock. Why? Because probably when he went to the ER before, he probably was septic. He probably had a white count greater than 12. He probably had a high fever or whatever. But all they cared about was he was 40-some years old. Oh, he's healthy. He should be straight. He'll get over it. No, he didn't get over it because these are early signs of sepsis. Yep. See, Kanisha had an uncle that died of this. A lot of times, sepsis is a preventable syndrome. Sepsis is not inevitable. It can be caused by any infection. So that our job, when you're going through your exams, your job as a nurse, we're taking care of people and we are protecting them. We are promoting the most optimal health for all people. and we are protecting them from injury. We are like the Congress to the president. We are providing checks and balances to the doctor. The doctors, they don't know everything. They don't know everything. They don't spend half as much time with the patients as we do. And, and they're busy. I'm not saying doctors are horrible people. They're not. And ever since I became a nurse practitioner and working from a provider standpoint, I see the amount of work, the number of patients they're expected to see. They are really depending on you as a nurse and your skills and your assessment skills. So with that comes the nursing process. So any infection, when it comes to anything that you do as a nurse, remember assessment comes first. You cannot administer antibiotics, IV antibiotics. The idea in the hospital is you must draw blood cultures prior to administering IV antibiotics. Most infections, the best practice is to obtain a culture first. Why? Because every antibiotic or every medication doesn't treat every single infection. It could be a fungal pneumonia versus a bacterial pneumonia. So without a culture and without identifying what the organism is, they're not going to be appropriately treated. But in the outpatient setting, that's different. Of course, does your doctor always swab you or anything? No, but they should. They should, because that's why we have super infections, because doctors just throw you an antibiotic, or providers, I should say, throw you an antibiotic without even doing a proper assessment. So therefore, that's why we need to check. Just because you have a sore throat doesn't automatically mean you have strep throat. So any part of the body, you could collect a culture. You do not collect a culture once antibiotics have been started. The results will be skewed, and there's no point. You cannot collect a culture. The results are not going to be accurate if a patient is receiving antibiotics. CBC, you're going to monitor that, of course, because you're going to look at the white blood cell count. Subjective data. All right, so we know you have an infection. So when did it start? When did you start feeling ill? What are your symptoms? Are you having any nausea? Are you having any pain? Are you vomiting? How many times did you vomit? Have you been exposed? What kind of questions we asked about COVID? Have you been exposed to anyone who had any infection? When Ebola first came out, when I was working in the ER, we would be asking them, have you traveled? Have you traveled out of the country? This is subjective data. This is the type of history you want to collect. And then the physical assessment. You want to look at, okay, are they hot? Are they flushed? What's their level of consciousness? Sometimes with elderly people, the only sign you're going to have is they're confused, more confused than usual. They may not have a fever. Like I said, that their immune system is slowed down. The baroreceptors in their brain that, control all these things, everything's slowed down. So they may not necessarily, have a fever, but the level of consciousness, is the person alert? Are they confused? Respiratory rate, lung sounds, obviously, if they have pneumonia, urine output. Urine output is going to tell me, are they having kidney issues? Are they having kidney failure? Things like that. And then abdominal sounds, maybe if they have diarrhea or something. This picture right here is a real picture of what a culture looks like. And that's why I wanted to show you guys the shift on I want you guys to put 2 and 2 together with what you're really going to see in life. So the doctor ordered a urine culture, you collected the urine using sterile technique, you collected a culture. You're always going to be sterile when collecting a culture. So if you're going to collect a wound culture, you are going to clean the wound first. Clean the wound with saline, not like some heavy duty antiseptic, but clean the wound with sterile saline first. Why? Because I need an accurate result. There's bacteria everywhere in the world. You'll get, if they don't, for example, everybody has done a clean catch urine at some point in their life. When I need a culture for urine, I need you to clean your perineal area first before collecting that urine, because bacteria from your skin can get in that urine and mess up the results. And you'll even see it sometimes. It'll tell you likely contamination. It was contaminated by just normal, healthy, the normal flora that lives on your skin or on your vagina. We need a sterile culture. And when you get that culture back, it's going to look exactly like this. S means susceptible, R means resistant. Is that bacteria susceptible or resistant to that antibiotic? So therefore, you're going to find out, okay, the person has an E. coli. I'm assuming this is urine. Yep, cysto, urine. So person has an E. coli infection in their urine. And it's pretty significant because they got over 100,000 organisms. So that's an infection. But if I've been giving them ampicillin, penicillin, anything that ends in cillin this whole time, what a waste of time, because it was resistant. Had I got the culture first, I would have learned that it was resistant to penicillin, and I should have been treating them with maybe a cephalosporin, because all these are susceptible. Or I should have been treating them with whatever, amikacin, whatever the case may be. Finally, diagnosis, planning, and interventions. So when someone has, we've determined they have the infection, we did our testing. Now my job as a nurse is to administer the anti-infective, whatever it is. If it's antibiotic, antifungal, whatever, we're going to administer that. We're going to prevent the spread by washing our hands, using PPE, yada, yada. Disinfecting equipment. We're going to control fevers and other symptoms, nausea, vomiting, pain, whatever. We're going to administer those meds, or maybe even use non-pharmacological approaches, whatever. Maybe monitor whatever diet they're on, depending upon what the infection is. We're going to monitor for complications or a worsening infection. Monitor their labs, vital signs. Signs and symptoms, of sepsis. And we're going to educate patients and families on transmission, prevention, and symptom management. And that's that. Any questions about infection?
No, ma'am.
All right, we're good. So, like I said from the first day, I want you to learn the basics first. If you don't know how to do a physical assessment, you probably shouldn't be looking at labs and all that. You get what I'm saying? If you don't know how the immune system works, I can't be teaching you about cancer. If you don't know, that's why things got to make sense. So, that's why I just want to give you the overview of immunity and the overview of inflammation. And as we go through each system, these things will come up again. So I was still working on the study guide, but I want to go over what I have thus far and then go through some practice questions. Is anybody concerned about any concerns right now about the exam? Nope. Okay, great.
How many questions is it?
100. 100 questions. It sounds like a lot.
Oh, wow.
It sounds like a lot, but it makes it easier for you to pass. Last semester, students I just read 500 chapters, 10,000 pages, and you're going to ask me 30 damn questions? That is not enough. You need to be ready for the proctor. You need to be ready for NCLEX. So answering 30 questions about 25 different topics is, I'm going to ask you what, one question on immunity? How are you going to be prepared? The other thing I'm going to do, 10 of those 100 questions are going to be math questions. It's not to punish you. It is to get you ready for the proctor. Remember, it's an exam, what, every 2 to 3 weeks? These exams aren't worth that much compared to that proctor exam that you have to pass. They're not worth as much as the NCLEX you have to be prepared for. And I cannot prepare you by asking you 10 little questions and giving you a study guide that has all the answers in it. So I'm gonna push you, but I'm not a jerk. I'm not here. I want everybody to pass. My goal is to be that teacher like, dang, everybody passed her class. How? Why? Because I did my thing. That's what happened. So it'll be 100 questions. It's going to be from home apparently now. The rule may change by tomorrow. I'll update you as it comes to me. But for now, the test has to be taken at home. If anybody has an issue taking tests at home, if that's not a good place for you, let me know. We'll work something out. We can go to campus. I'll figure it out. If you got 9 kids, 3 dogs, 4 birds, it's probably not going to be a good setting for you to take an exam. So let me know and we'll work it out. Any other questions? Oh, the other thing is, after the exam, after this class has taken the exam, because it doesn't matter, you've already taken the exam and the other classes have already, so you're going to be my last class to take the exam. So I want to actually go through the exam after we're done taking it. It's not to put anybody down. You don't got to sit here and share your score with everybody or whatever. But you need to know, where did you mess up at? So, no, it's ATI. ATI, they'll tell you right then, don't they? They usually tell your exam grade right then.
Not for the proctored exam, but the what do you call it? The adaptive, yes, they do.
Oh, so you don't get your test score right away.
I mean, yeah, the test score, but I'm talking about what mistakes or you did wrong or something like that.
Yeah, that's what I'm saying. So you do get your score right then and there, right? I thought somebody was asking, okay. So yeah, after.
Yeah, that's what I was asking. Some last semester for one of the tests, the professor, she blocked it so we couldn't see our score right away because she wanted and then she ended up posting it in Moodle after everybody was done.
Oh. I mean, whatever. I don't got time to do all that. We're just going to find the ATI will just tell you what your score is right then and there. Maybe she blocked it because she didn't want you getting up and running out crying in the middle of the class or something. I don't know. But for me, what worked for me, I need to know, what did I get wrong? What didn't I know? If I don't know, I'm just going to go to the next test trying to guess which questions I got wrong. And when I was in nursing school and I went to a big university, a dual accredited university, our tests were on paper and pen. And after the exam, when every student in the program had taken the exam, our teacher would go over the exam with us to teach us, to figure out what didn't we get and teach it to us so that we would be prepared for the finals and we didn't have all these high stakes exams, but for NCLEX, that's a high stake exam in itself. So yes, for your class on Thursday, we will take the exam, and when everyone finishes, we will go over the exam. You don't need to sit here and tell everybody what you got wrong or what you got right. It's not about that. I'm just
that's really nice, because from the first semester, it's I don't know if I did it wrong, but I don't know if I keep answering it wrong.
Right. You're gonna keep using that. Okay, I'm pretty sure I got that one right. I'm gonna just keep going with that. No,
Yeah.
No, I think a lot of times, unfortunately, I don't know what's wrong with this female dominated field. I don't think is there any men in this class today? I don't think, is there men in this class? Some names, I'm not sure. Okay, I'm not sure. That could be a man. I could be wrong. But anyway, whatever, you're going to find it. People say it all the time. Nurses eat their young, right? This is a female dominated field. I don't know what's wrong with us women, okay? We can't just uplift each other. But I bet you every woman in this class was damn near at tears, no matter what your party affiliation is, to see a woman as a vice president. I don't care what your party affiliation is. Everybody should be happy to see a woman doing something great. But for whatever reason, I don't know why we have to attack each other and be so mean to each other. And for some reason, there's so many nursing instructors. Like I said, you think it's like a competition. Like, let me prove to these students how much I know. I know everything. And they're never going to be nurses like me. Well, that's not a good attitude to have. My goal, like I said, I want everybody to pass this class and move on with their lives. I like you, but I don't want to be talking to you again about this stuff next semester. So with that said, I still got a couple things I want to add to the study guide, and then I'll post it. But I'm gonna open this up, and then we'll go over that, and then we'll do some practice. And then we'll go home, or we'll stay home, or whatever the hell you're going to do after you get done here. Where the heck is my, oh, here we go. Okay, let me share. All right, so what I did, I just started adding on to the study guide from last week, but let's go through and talk about this. So week one, was health, wellness, illness, and development, yada, yada. Week two, immunity, inflammation, and infection. We talked about the different the different categories and how they relate to NCLEX. So for management of care, I need you to know what are advanced directives, what are each of them, what is a DNR, what's a power of attorney, a healthcare proxy, which is pretty much the same thing, power of attorney of healthcare. What are they? What do they mean? When is a DNR valid and when is a DNR not valid? Okay, when is a healthcare proxy appropriate and when is it not appropriate? Anybody can be your healthcare power of attorney. Anybody, if I want to designate my mailman, because we're cool like that, I can designate my mailman to be my healthcare power of attorney or my healthcare proxy. There's no rules on who you can choose for that. The other thing is, I'm trying to close that. Okay, make it a little bigger. Okay, the other thing is safety and infection control, right? Medication safety. So any medications we discussed, knowing about NSAIDs, knowing when NSAIDs are safe to be used, when not to use them, what kind of education, knowing about corticosteroids, what is the intended effect and what are the side effects. It's in the slides, the side effects. And if there are side effects, for example, what can you teach the patient or what can you look out for as far as those side effects? HIV medications. I said it already, the serious adverse effects that could occur with HIV medications. Another one, those immune suppressant drugs, specifically methotrexate. Knowing those immune suppressant drugs, just knowing what to be considerate of. Now, week one, health promotion and maintenance. Okay, I need you to know about health promotion across the lifespan. There are going to be multiple questions about development. There's going to be multiple questions, for example, like this toddler is exhibiting this behavior, you know, is that behavior normal or not for a toddler? Or if they have you know, if they're in the hospital, what is their response to illness? What is their response to illness? What are certain behaviors? What are ways you as a provider could work around those behaviors? Okay. Family structures. There is one question on family and there is one question on culture. They are pretty much common sense. So those are like two freebie questions, but I'm pretty sure everyone knows the difference between a blended and extended and nuclear family. You didn't need to come to HCI College to learn that. And it's not a specific for me. I mean, we joke and everything, but for me, I don't really like those like culture specific questions unless it's like a religious practice, because how am I going to say how all Asian people respond to pain? That sounds a little racist to me. So I don't really like those questions. But there's just one very common sense question about culture. Anticipatory guidance. Again, this is health promotion. How, you know, being familiar with how these patients, and plus culture, that's in fundamentals. I'm over that culture stuff. Because as you can see, everybody, I mean, culture is about who you are around. It's not about the color of your skin. Depending on where you grow up and what your family values are and things like that is going to determine how you respond and behave. So yeah. So anyways, so knowing how to educate families, parents, and knowing, for example, a lot of it has to do too with the leading cause of death for each age group. For example, for infants, the leading cause of death, or for newborns, at least infants, it's congenital anomalies. So that starts with educating the pregnant woman on how, you know, possible ways. Yep, SIDS, you know, preventing SIDS, stuff like that. Am I going to teach a mother of a 12-year-old how to prevent SIDS? No. Why? Because the 12-year-old's not going to die of SIDS. You missed your beat. They survived that. So just knowing that adolescence and stuff is going to be geared more towards risky behaviors, you know, and things to prevent injury, driving with the seatbelt on, those kind of things. Knowing the proper car seats for certain children, that kind of stuff. Any mom in the room, a lot of those questions should be kind of easy. You do need to know your immunizations. That's why I put that chart in the slideshow to make it a little easier than the CDC chart. But basically, you need to be aware of immunizations when they're given, contraindications when not to give it. What's not appropriate, you know, for a pregnant woman or immunocompromised person. Understanding disease prevention and individualized patient education. So understanding the different variables that affect health and wellness, modifiable versus non-modifiable. What's the difference? Stages of prevention. What is primary? What counts as secondary? What is tertiary? Remember, primary is education only. Secondary is when we're doing something to the patient, whether it's drawing a blood, like doing a cholesterol screening, administering some sort of test, giving them a vaccine. That's secondary. Tertiary is now this person has a disease and we are just trying to optimize the outcome, prevent exacerbations, or prevent, you know, manage symptoms. Age-related adjustments to illness, I already said that. You need to know about how a toddler or a school-age child or whatever is going to behave. What's up? Somebody needs, somebody.
I have a question.
Oh, yes.
Last year immunizations was kind of under primary. Are you considering that secondary?
oh, hold up. Let me not misspeak. They said immunizations was primary prevention.
Yes. Mm-hmm.
Does it say it in your book?
Yeah, they said immunizations was primary.
In the book? All right, go by what the book says, not by me. So giving
Okay.
vaccines, what page is it in your peds book?
It was in the fundamentals book last semester.
All right.
Yeah, I was in fundamental.
All right, if you find it, if somebody remembers it and finds it in, actually, I'll look it up just to be sure. I'll give you that answer in an email. There you go. One more freebie. There you go. Call me out. I don't know everything. Shoot. And honestly, too, that goes for the exams. I told everybody the reason I want to go over the exam too is last semester when I was helping the clinical students I had doing their med surge reviews and stuff. Oh my God, we found questions that weren't even accurate. They were not even accurate, like totally contradictory to the reading, totally contradictory to facts. So that's what I want to go through too. Nobody knows everything. Nobody's perfect. ATI isn't perfect. Shoot. So yeah, so I want to go through and take questions. Okay, page 86 in fundies. Okay, I'm gonna look that up. All right, long as it's in the book. All right, so don't quote me on that one. All right, in the life psychosocial. Basically the most of the psychosocial stuff we talked about this semester had to do with grief. I mean, semester this week and last week was grief, end of life, understanding the concept of hospice. Oh, and also, let's say, and the services provided. You need to know about interdisciplinary care and respite, etc. All right. So services provided by hospice, stages of grief, knowing denial versus bargaining versus whatever. You need to know that. And then normal versus maladaptive. Maladaptive grief is that overwhelming grief, and we're not talking about parental grief. Like the grief my friend is going through, that is probably going to last the rest of your life. But maladaptive grief is like per the textbook, after lasting longer than 6 months, it's sending the person into a deep depression. It's affecting their life. They can't get out of bed. It's lowering their self-esteem. That's when it becomes maladaptive. And then the physiological integrity. So you need to know about physical assessment. Like I said, we're starting with the basics and we're working our way up. You need to know head to toe assessment and how to perform. There are going to be questions about assessment. Nothing too crazy, but you need to know, anatomical landmarks, how to check, where do I put my stethoscope to listen to an apical pulse? Where do I, at what age is appropriate for you to be measuring head circumference or assessing different things? Dental findings, do I expect a 1-year-old to have all their molars and things like that? So again, while I tried to cover as much as humanly possible in lecture, you do have to read your book too. Understand how to keep patients comfortable, preventing pain. So you need to know how to assess pain, know the different scales, know how to assess pain. What are some cues, some nonverbal cues that a patient is in pain if they're not able to communicate? Considerations, again, with the meds, administering opioids, knowing the side effects, the adverse effects, knowing what to look out for, safety when administering opioids, appropriate use of a PCA pump, who's supposed to be pushing the button and that kind of stuff. And then now disease-specific considerations. And that is, so the few diseases that we did talk about, and I haven't finished, this is a part I was typing up. So you're gonna need risk factors and for Down syndrome, congenital and other congenital anomalies, because a lot of them are the same. You're gonna need to know about the physical characteristics of Downs. Cerebral palsy, what are the risk factors for that? And what kind of physical and clinical manifestations you may see? You want to know about preventing hospital transmitted infections and things like that. MRSA and other antibiotic resistant infections. You're going to need to know about lupus, clinical manifestations, all that, treatment, nursing considerations, and patient education. All right, that's going to be the same for rheumatoid arthritis. You also need to know referrals. Who might you refer these people to? Who's an appropriate referral? So I'll put that, and that's going to be for every disease. So for rheumatoid, for HIV, and knowing about HIV and AIDS, what's the difference? Trying to think. I think that's it. Those are really the diseases we covered. Understanding autoimmune disorders. Let's see, immune function and humoral. Oh God, don't get me started. I can't spell. Versus cell-mediated immunity.
What did you say we needed to know about rheumatoid arthritis?
The same as the clinical. So all these are going to be the same as what I put for lupus. You just really need to know about the disease, clinical manifestation, what kind of symptoms might that person have? What kind of specialists might you refer them to? For rheumatoid arthritis and lupus, those are autoimmune diseases. So you're gonna refer to a rheumatologist. But again, lupus, you may refer them to a dermatologist for skin, right? Or you may refer them to, and by you, I mean the doctor, I don't mean you, but you may see a referral, or you may ask the doctor for a referral. But lupus, so dermatology for the skin, or even a nephrologist if they are having issues with their kidneys. Rheumatoid arthritis, again, a rheumatologist deals with autoimmune disease, so they will be referred to rheumatology, but they may also be referred to PT or OT. So those are referrals. So just in ATI, it does discuss that. HIV, AIDS, same things. What kind of labs and stuff are you looking at? Let me put that in here. So symptoms, labs, etc. Okay. And then with HIV, you also need to know the stages, like initial, versus later, right? You need to know side effects, like I said, of the HIV treatment, manifestations of HIV. Definitely need to know about CD4 cells. That is what is being affected by HIV and AIDS. So I've said the word CD4 enough. And then understanding the immune system, immune function, how it works. Definitely, you're going to need to know the difference between humoral, which is B cell, we're related to the B lymphocyte cells, and the creation of antibodies, versus cell-mediated immunity. And how they relate anaphylaxis and hypersensitivity, right? All right. And that's pretty much it. Like, I know it seems like a lot, but I really have faith that you guys are going to do really well. I have posted, I'm going to post more today. I posted all the reading from the pink ATI book, the NCLEX review ATI book that for whatever reason is like something they want to keep a big secret until you're halfway done with leadership. But I just post the chapters that are pertaining to what we're talking about, just to give you some more, ATI material on the disease, whatever issue we're talking about. I also posted some practice questions, case study things with the answers to help you study that. That way, I mean, everybody has their own way of learning. Some people just need to read and then they know everything. They have photographic memory. Some people like Picmonics with flying cars and, different random drawings. That works for them. Some people just watch YouTube. So whatever the case may be, whatever works for you. How many select all that apply? Oh, I think it's only a couple, like 2 or 3. Not much, maybe 2. It's not a lot. And then there is going to be 2 where you need to put something in order. You're going to put stuff in order. I think there's like 1 or 2 select all apply and 2 for sure where you're putting the steps in order. But other than that, the rest is multiple choice. And except for the math, I can't say the math. That's math. 10 math questions. So you know how the math is. Any other questions?
Are we taking it as soon as we log on Thursday at 9?
Yes, we're gonna take it first thing and just get it over with. So then we can go over the results. Go over the questions. Somebody asked, is the pink book the NCLEX book? Yes, that's the book I'm talking about.
Do we have
But it does have a section, like everything that's in all your books, they have a section in the pink book too. Somebody asked something else?
I was asking if we have that book, that pink book.
No, you don't. For whatever reason, HCI, they only give it to people next semester, like damn near the end of the semester. I guess because they want you to read your other books and not be going straight to that, because almost like Cliff Notes, but I'm still going to give that to you. Whatever gets you to understand the material and be a good nurse. I mean, I don't really care. I'm not about hiding information. You can buy the book on the internet right now if you wanted to. No, it's not like Saunders, but I do have Saunders if anybody wants that book, the Saunders NCLEX review.
Do you think it's a good review for your exams to go because I have Saunders, but I don't know if I should if it's good.
Definitely. I mean, the thing is especially when it comes to the diseases and stuff, yes, this is science. These are facts, okay? Yeah. With all these people out here that don't believe in coronavirus, you could say you don't believe in science as much as you want, but the immune system is the immune system. That's why I like Med-Surg. Yeah. I don't like theory and all that. This is not a theory about how these cells work. These are facts. So whether you read Saunders, whether you read ATI, whether you read whatever, the facts are facts. Science is science. I don't recommend going to WebMD, but I do recommend, yes, if Saunders helps you understand, for some of you, if you were a waitress and you have never been exposed to any of this crap, that Lippincott might be too much. You might not be able to understand everything you're reading. The whole point, do whatever you got to do to understand. The other thing I think I failed to mention to your class, homework. Okay, this is my first semester teaching this class at HCI College. So the syllabus I inherited from other instructors. I believe it was created by Professor Christmas when she taught the class, and then maybe adapted a little bit by Professor Leandre and Colia. So with that being said, when I went to nursing school, my grade was only based on 4 exams. So I think you guys are lucky to get like participation points and everything else, because I swear to God, every class, 4 exams, 25% of your grade each. So you fail one, your life is over. We didn't have homework. We didn't do anything. Why? Because the whole point was we needed to understand. All we could do was read and understand the learning. But again, we had lecture 3 days a week and clinical twice a week. So it was a little bit different. But for you guys, I don't want you obsessed with just getting these assignments done. So with that being said, moving forward, all I want to see is everybody has spent a minimum of 2 hours in ATI and 2 hours in Lippincott per week. I don't care if it's 30 minutes a day, every day. I don't care what activity you're doing in there, because like I say, I cannot give you a module and I know that you're going to learn from that module. If you're like me, you probably just clicking the over arrow and hurry up and get me up out this module so I could turn it in and say that I did it. But it was useless and I didn't learn anything. So with that being said, moving forward, like doing the 6-pick monics and all that, I don't even, at this point, let's just learn the material, master the material. It's not a competition. So yeah, there is a collection of the Farm Made Easy and practice tests and ATI. Yeah, there is. Farm Made Easy, it should be a collection of the Farm Made Easy. I don't understand the question. There is a collection in ATI, yes.
So Professor,
Mhm.
so that 2 hours every week on ATI and Lippincott, do we need to like
You don't need to do anything. I can look in there and just
Oh,
tell
okay.
you how much time. You don't need to do anything at all. My point is, we are here to breed good nursing, period. Good nurses.
Amen.
That's what the world needs. These old nurses are aging out. There's a shortage of nurses. Everybody has been exposed to what's going on in this country for the last several years. Prejudice, racism, bias, none of that has any place in healthcare. Okay, what we have to do, whatever you learn from your family, your values, have no place in healthcare. All we're doing is taking care of people and educating them about their health and promoting health with them and respecting their values and where they come from. So all I need you to know is how to do that. I don't really care how many tedious assignments you do. If you spend 2 hours actively working in ATI and Lippincott, 2 in Lippincott, 2 in ATI each week, I don't care if you're doing adaptive quizzes. I don't care if you're reading. I don't care what you're doing. 2 hours in each week, and you read your book and come to class. I will give you the 5% participation grade. Is that cool with everyone?
Yeah, so just to clarify,
Yeah.
because I think my computer kind of like, went off, so I didn't hear the whole thing. But just to clarify, so we don't really need to like submit anything in Moodle.
No, you do not need to submit anything. One, I
Thank
don't got
you.
time to be nitpicking and going through and reading I don't got time for that.
Thank
You
you
don't
so
have time for that. You are in an accelerated program. You have 1 semester to learn med surg, pathophysiology, health assessment, and peds in 1 semester from 1 teacher for 6 hours a week. So I don't need to pick how you're going to learn. You're going to watch this movie and you're going to know everything. You may not be a visual person. So I don't care what the hell you do, as long as you're mastering the material. That's all you need to do. Study, 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 read, take notes, draw pictures, but spend at least 2 hours because Lippincott and ATI are very useful resources. Your tests are coming straight out of ATI. So they are useful resources, but they have so many things, like one person may like Picmonics, one person may just like to quiz themselves to death. So I'm not going to tell you what you have to do, aside from I am just going to look at every class and see who's not spending 2 hours per week. And that's that. All right. So we could do some, what'd you say?
Or do you recommend us reading more, like from the doing our reading from our textbook or the ATI books, since most of our questions are from ATI?
The problem with ATI is it's too basic.
Yeah, it's too vague.
Too basic.
Mhm.
I would even like moving forward this weekend, I plan to post the PowerPoints, right? For next week. I want to post them in advance. Why? Because the PowerPoint should be an outline. I don't have everything on the PowerPoints. Of course, there's so much information. Some stuff gets lost or forgotten. But if you look at the PowerPoint and then you go back and you look at Lippincott, you get a little more detail. You get a little more detail in ATI. I definitely recommend reading Lippincott. Lippincott is a real textbook. Those books you guys have, ATI, that's almost like a study guide. So I would take the PowerPoints and look through them before class, and you can kind of gauge what all you need to read. Now, I know in Lippincott, oh my gosh, there is so much, like you might be reading 1,000 pages. So again, some stuff, that's why I say look at the PowerPoint, because some stuff you don't need to waste your time reading about. Just remember nursing considerations. I'm becoming a nurse. Those are the only things you need to be concerned with. What is my job as a nurse? What do I really need to know?
I wish we can take you to semester 3.
Oh,
Really?
you can always reach out if you need anything.
Oh, that's sweet. Thank you.
You're welcome. Me, I love nursing. I love people. I'm not from the South. I'm from Chicago. I love everybody. I don't know nothing about racism and things like that. Not a hateful bone in my body. And one thing I've seen in nursing is a lot of people that don't belong in nursing. And my goal is if I can make everybody feel about people and nurses the way, nursing, our job, how proud I am to be a nurse and the difference we make in people's lives. That's all I want to do. I don't want to be working side by side with no stuffy old racist nurse. Take your butt back to the country or wherever you came from. I don't want to work with you. I would rather breed the new age nurses who actually care about people, who care about making a difference in people's lives, who care about educating people before they even get to the point of hospitalization. We don't need all these health disparities in America, but people can only do what, you only know so much. If you don't know, you can't help what you don't know. And if you know better, the hope is that you'll do better. Is that everybody? Heck no. Many of us know we shouldn't smoke cigarettes and we still smoke cigarettes. Doesn't matter. My job as a nurse isn't to judge you and put you down and make you feel like crap about yourself because you smoke. But my job is to educate, promote, and maybe try to figure out to work with you on ways we can get to quitting smoking. And that goes for everything. So with that being said, let's do some practice questions and then let's get over this. Hold on, what screen am I sharing? What can you see right now? Help me.
The study guide.
Oh, okay, hold up. Okay, stop share. Hold up. And I'm gonna touch it up and then I'll email it to you. Okay, now I want to share this little. All right, time to show up. So you've been reading, you think you know something, so let's see what you know. So the nurse is caring for a client during the first trimester of pregnancy. After reviewing the client's blood work, the nurse notices she does not have immunity to rubella. Which of the following times should the nurse understand is recommended for rubella immunization?
Maybe number 4.
1.
2.
So
3.
1.
Yay!
The MMR vaccine, mumps, measles, and rubella, is not due until a child is 1 year old, and it is not appropriate for pregnant women. So the way I was saying before, I remember it is usually most times if the immunization isn't given to 1 year old or older, it cannot be given to a pregnant woman. So if it can't be given to a small infant, it can't be given to a pregnant woman. A nurse is teaching a client who is 23 weeks gestation about immunizations. Which of the following, I did it again. I forgot to put number 4 on there. But which of the following statements should the nurse include?
3.
Yes, 3.
Mhm.
Oh, and I skipped the whole answer sheet. But anyway, 3. The answer is they should not be, again, that's a live vaccine. They shouldn't take it while they're pregnant. They shouldn't be taking it while they're breastfeeding.
Can you put it back up real quick? I just want to take pictures of them.
Oh, okay, hold up. How do I go back?
No. Yeah. Okay, thank you.
Actually, what I'm going to do, I'm probably just going to post this video of us talking about the study guide and these questions too, if I can. If I didn't say anything too inappropriate in the way, in the video. All right, older client is scheduled to have an elective procedure and informs the nurse that she wants to be designated as a do not resuscitate case. Which of the following responses would the nurse provide?
4.
Yes, 4. Obviously, if you're having a procedure, why would I get this after the procedure? And why am I gonna assume, did it say anything in here that the person was religious? So why would they be talking to a chaplain? Telling someone this is a minor procedure, please. People die of crazy stuff all the time. All right. Nurse is completing a physical exam of a client and notes the lab values indicate leukocytosis. Nurse should recognize which of the following is a manifestation associated with leukocytosis.
3.
3.
3. Yay. What might be a sign of anemia? What's going to be low with anemia?
Iron.
Hemoglobin?
Hemoglobin, yep, red blood cells, hemoglobin, hematocrit, those are red blood cells. What about coagulation disorder? What might be low?
Platelets?
Platelets, yes. And what labs do you look at for renal disease?
Bun and creatinine.
What? Y'all, I said it was time to show out. Y'all showing out. All right. So now, nurse is reviewing the lab results of a client who has acute radiation syndrome and notes, again, see, this would have been a couple, I pointed this out. ATI, all I did was copy and paste, people. But why is it saying the client has leukopenia, but then asking what is consistent with leukocytosis? I believe what they meant to write was leukopenia. Or this used to be leukocytosis, but why would they put both words there? But anyway, what answer is it?
3. Tyler.
1.
1.
Fever.
Fever. What's happening in leukocytosis? They got the high white blood cell count. They are fighting the infection, right? The white cells are high, they're fighting infection, and they're the other thing I did not mention with neutrophils, but it's in your reading, is when that action is occurring, neutrophils have a pyretic effect, meaning they cause your body to heat up, leading to fever. So high white blood cell count is consistent with a fever. Bruising. is consistent with what? Bruising and petechiae actually are consistent with bleeding, right? You'll be worried, this person, is their blood too thin? Are they bleeding? So bruising and petechiae at the bottom, which is those little, we'll talk about petechiae in another week or whatever, but I just want you to know all the answers. So fever is with leukocytosis, but bruising and petechiae will go with platelets. Your platelets are low, you're at risk for bleeding. Signs of bleeding will be bruising and petechiae. Pallor means your skin is pale, you're ghost, you look like a ghost, you're pale. That comes from a low red blood cell count and anemia. That will be pallor. I mean, yeah, pallor. What am I talking about? Okay. And all right. So a nurse is planning care for a client who is being treated with chemotherapy and radiation for metastatic breast cancer, and they have neutropenia. Nurse should plan which of the following restrictions in the plan of care?
One.
Two.
Two.
Two. Dos.
Answer is two. So just because I'm on neutropenic precautions, that would be horrible if nobody could ever visit me. But if my visitor has a sickness, if my visitor is feeling under the weather, they should not visit. You should limit the number of visitors. I mean, Miss Johnson can't have the whole church choir come visit her at the same time, but they are allowed. We're not restricting the visitors. They can have visitors. However, we are not, if a visitor shows up with a vase of fresh flowers or something like that, we're sending them out of the room. We aren't even allowing them to go in the room with that. They have to stay at the nurse's station. Obviously, why would you limit their fluid intake? That makes no sense. And then the bleeding, again, bleeding has to do with low platelets. What's the medical term for low platelets?
Thrombocytopenia.
Yes, thrombocytopenia. Cytopenia means low. Thrombocytopenia means low platelets. All right. Nurses caring for a school-age child who has a systemic disorder and is receiving antibiotics, immunosuppressants, and corticosteroids. Both of the child's parents smoke. The child reports soreness in his mouth and refuses to eat. Inspection, of his mouth reveals a white milky plaque that does not come off with rubbing. You should suspect which of the following?
A. One.
One.
Y'all were listening. 1, candidiasis. That is the fungal infection. That is fungus, and it causes oral thrush. Thrush is what kind of infection?
Bacteria.
Opportunistic.
The bacteria or
I'm sorry, it's a fungal. It's a fungus.
fungal? Okay.
And it's a candidiasis is a fungus. Oral thrush is a fungal. It's the same as a vaginal yeast infection. It is caused by candidiasis. So candidiasis and fungal infections are usually opportunistic. So this patient's been on antibiotics, they're on immunosuppressants and corticosteroids, which also suppress the immune system. So now that gives the fungus the opportunity to come in there and wreak havoc. So that's an opportunistic infection, candidiasis. Dermatitis just means inflammation of the skin. Anything with itis at the end means inflamed. Herpes, I mean, I don't know why we would think the kid had herpes, or squamous cell carcinoma. Again, candidiasis is the only answer that would make sense. So a nurse suspects anaphylaxis when caring for a child or client, following the initial administration of an oral antibiotic. Which of the following should be the nurse's priority intervention?
2.
2.
Yes. Even though in all actuality, all 4, I don't know how I messed this up, but all 4 should be getting done at the same time, right? Usually in a real life situation. But when it comes to NCLEX, when it comes to these tests, always remember the nursing process. Assessment is first. Assessment is first. Then remember ABCs, breathing, because see, all these had to do with oxygen has to do with ABC, but that's an intervention. Intubation has to do with maintaining the airway, but that's an intervention. Always assess first. Nurses performing discharge teaching for a client who has lupus. Which of the following instructions should the nurse include?
4.
Oh.
So this
4.
is one of those trick questions. They want you to pick 4. Why? Because it says sun blocking, right? You need to protect lupus from sun.
Is that one?
It's B.
It's
Two.
B, B2.
Yeah,
Why?
that's why. Yeah.
Because of this 15 right here. I believe the minimum SPF should be at least 30.
30. Yeah.
So that is, so they'll try to trick you, right? You were right with the sun blocking. You had the right idea. But they're going to try to trick you and add that little detail there. So you are going to tell them to wash with a mild protein shampoo. Everybody needs, look, anybody ever heard the Vaseline commercial? Everybody needs Vaseline. Everybody needs lotion. Everybody needs moisturizing your skin, maintains the integrity of your skin. Hence why moisturizing your skin earlier on helps prevent the drying out, loss of collagen and elasticity and wrinkles, right? So everybody needs to moisturize their skin. The powder has nothing to do with this. And then we already talked about the sun blocking. This is another one. So nurses presenting at a community center about systemic lupus erythematosus. Nurse should plan to include which of the following findings as a manifestation?
4.
4,
Yeah.
a raised rash. Oop, a raised rash, right? Like the butterfly rash. But they could have a rash elsewhere, but a raised rash, like the one we saw on Seal's face. All right, now you need some scratch paper. So I'm not gonna read this to you. You could read it yourself, but let's see what you get.
I got 4. 4.
All right. Anybody else get 4? Anybody else got? Oh, I see the chat. Hold up. Let's see what people got. 4. All right. Somebody tell me how you got 4. What did you do?
I did 150 divided by 720 because 12 hours times 60 and then times 20 and it gave me 4.16 and I rounded it and I got 4.
So I'm going to tell you what happened. First of all, the 12 is irrelevant.
Mm.
The 12 is irrelevant, right? The correct answer is 50.
Mm.
And this is why. So the 12 is irrelevant. What are they asking you for? They're asking you for how many drips are in a minute. How many times is it going to drip per minute, right?
Mhm.
What I do know is it's going at 150 mLs an hour. I do know that. All right. So if it's going at 150 mLs an hour, that means it's going at 150 mLs per 60 minutes, right? I got to get to minutes. So I'm going to divide 60. I'm going to divide 150 just by that 1 hour, by that 60 minutes. And that's going to give me 2.5. So now I know it's 2.5. It's 150 mLs an hour, but it's 2.5 mLs per minute. All I got to do now, I know how many mLs per minute. Now I just need to figure out, I know it's 20 drops per ml. I just need to figure out how many drops per minute, right? So if it's 2.5 mLs per minute times 20 is going to be 50. They threw this 12 hours in here
It makes sense.
To confuse us.
Oh, that's like not how we were taught though. So it's like that's.
Good to know.
Yeah, I think the 12-hour is the distraction.
We were always
Yeah.
taught, we should see the hour, convert it to minutes, then divide, like how we all did it.
Well, you converted, yes, 1 hour to 60 minutes. This is the hour you need to be converting. This right here is just some added nonsense to make you think you need to put this in your equation. And this is exactly how NCLEX and how these math problems are going to be. So, and that's why I emailed you guys a practice for you to keep doing it. Keep getting in the habit of them trying to trick you and getting in the habit of recognizing what is the question really asking me? What do I really need to know? And we'll do a couple more math. We're almost done. So one more. Nurse is providing care to a child who has an allergy to eggs. Which prescription would you question?
3.
3.
Yes, 3, the flu vaccine. You're going to question that if they have an allergy to eggs. Next, a nurse is giving a presentation to a community group about preventing atherosclerosis. You don't need to know what atherosclerosis is to answer this question, but it is the plaque buildup on the arteries causing hardening of the blood vessels. But anyway, which of the following should the nurse include as modifiable risk factors?
2, 3,
4
4,
and 5.
3, 4, 5.
Yeah, 3, 4, 5. 3, 4, 5. 4.
So
Everything but number 1.
everything but number 1. Why? Because any of these things can change.
Modifiable.
Just because your cholesterol is high doesn't mean you can't take Lipitor and get a good cholesterol. I can lower my cholesterol. I can lower my blood pressure through good diet, exercise, and medications. If I'm on blood pressure, hypertension meds, obesity, it may not be easy, but I can lose weight and I can definitely quit smoking. So again, hypertension, even though it may be a diagnosis, you could still manage your blood pressure. If I have hypertension, it's not that I can never again have a blood pressure that's perfect. That's the goal. That's the whole goal. Take your meds, maintain a low sodium diet and exercise. And we want your blood pressure as close to 120/80 as everybody else's. Nurse in an ER caring for a client who has anaphylaxis following a bee sting. Which of the following actions would you take first?
1,
2.
1.
Oh, first. I'm sorry. 1.
3.
2.
All right, here we go again. One, they tricked you because they put the word assess and they know you want to assess first. But this is another assessment, and this is speaking to ABCs. These are while monitoring for hypotension there's 3 assessments in here actually. These are all assessment, but now you got to remember ABCs: airway, breathing, circulation. So anytime I'm assessing respirations, lung sounds, I'm assessing first. In real life, honestly, if you've already, I mean, you're going to already know the person's wheezing and all that. You're going to be doing all this all at once. But for the sake of exam taking, remember the nursing process. All right, so you see assessment. So, okay, if I looked at this question, all right, I see 3 assessments. Shoot, okay, which one? Which assessment do I choose? Now I got to remember which assessment is priority, and that's always airway, breathing, and circulation. Everything else comes next. All right, nurse is caring for a client who has an NG tube sets. Oh, well, you guys can read this because it's another math question. All right, looking good, people. 415 is the answer. And why is that? It is because you do not count the fluid that you use to irrigate. You put that fluid in and sucked it, got it to come back out or whatever. So that does not count as drainage. So I don't know why I wrote, what am I writing? I wrote milligram right here. It's supposed to be a milliliter. But anyway, everybody get that? That wasn't hard, right? Any questions? No, everybody got 415. All right, cool. I want to boost your self-esteem back after beating you down with the other questions. So here's a weight-based math question. I believe this is the last one or second to last.
Three point three.
Okay, who got 3.3?
3.3.
All right, now y'all doing some math. 3.3 is the answer. Good job. So for those of you that didn't get it, I got the what happened here. First, of course, you need to figure out how many kilograms does a person weigh. We can't do anything with pounds. So 12 divided by 2.2 is 5.4545. But we're gonna round it. So we'll round that first to 5.5 before we move on. Next, we need to figure out how many milligrams. So X amount of milligram per kilogram. So if it was 15 milligrams per kilogram, then it's 15 times 5.5. That's what got us to 82.5. Here they rounded, which I mean, you probably would come with the same answer, but anyway, so you round that before you move on to the next step. Finally, I need 83 milligrams, but I have 125 milligrams per ml or per 5 mLs. So first I need to figure out how many milligrams is in 1 ml. And so if there's 125 milligrams per 5 mLs, how many is in 1 ml? And then by that, I do that ml times 83. Well, that's how I would do it. But I know they tell you, you doing all this cross conversion, but basically 5 going into 125 would be 25. What's 25 milligram? Oh, wait, what am I doing? Somebody help me out. I'm getting sleepy. What is, yeah, we have 125. So we're trying to figure out how many mLs to give them, right?
Yeah.
You see it. I'm not a math teacher, but I know how to do the math. But the problem is I don't know how to teach the steps of
You did it right. But what threw me off was the every 12 hours. I had like doubled it.
on the first one, right? Yeah. Or you're talking about this one.
No, this one. Like
Oh, right. So some may, if they asked you what the dose would be in 24 hours, right? If they asked you, what would the dose, how much would you give them in 24 hours? Then yes. But right, that's where they threw you off too. Yeah, they threw 12 hours in there and the 12 hours doesn't matter. You get it?
Yeah.
And that's all I got. But anyway, like I said, I'm not a math teacher, but I will try my best to help you guys with the math. But I did send you straight out of ATI a whole bunch of practice questions. And then in Moodle, the answers with the work, like the steps, is posted. So anybody who's having trouble with math, I recommend you, take the time and do the practice test and then check your answers and see where you messed up. If after you do that and you still have no idea what's going on, please let me know and I will help you out. I am going to put some weight-based. It'll be a couple of each, like weight-based and dosage. What was the drip factor?
Can I add something?
Yes.
Okay, sorry. For the girls, we have like these math quizzes for mental health. It's math quiz 1, 2, and 3, and it has all of the weight base and the drip factors and stuff. So I did those last night, and then most of the questions that we were just given were on there. So that helped a lot too. So if
Oh
you're
yeah,
kind of struggling
Professor
with that,
Coley is good at that, giving you a lot of practice from ATI.
Mhm.
So yeah, if you have that, Carly, or if you could share, or everybody should have it, right?
It's an ATI.
Okay, all right, yeah. So I would recommend, if you're having trouble with math, doing those two. Those are the modules I do recommend doing. Is the practice math. If you're, like me, math was always my strong suit. My son, same. Now it's at a point I got to go to my son so he can make me remember how to do math. But for some people, math is not your thing. So if you know math is not your thing, then you need to, I have had people reach out to me to let me know, look, math isn't my thing. So that's why I want to make these practice tests. I don't want anybody to fail this class based on math, because we can do this. We can do it. We can get through this. So every test, I am going to put 10 math questions, only because that proctor, for some people, they didn't get any math practice and they were just throwing a proctor exam, and that's not fair. So that's that. Any questions before we get out of here?
Is our exam basically the questions going to be kind of like how you just went over, like pretty straightforward like that?
Yeah, pretty straight. Honestly, everything on the exam we have talked about to some degree. Might be a couple things you may have to get directly from your book, but I have touched on everything that's going to be on the exam. The questions will be like that, but remember, it may seem easy, but then they're going to try to trick you. There's usually always 2 answers that seem like they should be right. So it is going to take some critical thought. But like I said before, I think if I remember, I got the test with me. I only think there's like one or two. I think there's two all select all that apply out of 100 questions. And there are two where you have to put something in order. Other than that, the rest are straightforward multiple choice.
Okay.
And yeah, and that's it. Any questions? Any other questions? I'm gonna touch up the study guide and post it, like, give me like 20 minutes. I just wanted to make sure I got everything on there.
Thank you.
Well, sorry, I thought we would get out a little bit earlier than this, but whatever. Long as everybody feels prepared. So next week, the test, please be on time. And let's be ready to start the test right at the beginning of class, like 9:15, starting the test. So we can get it out of the way, go over the answers, and then move on with our life. All right. So everybody have a good weekend. If you need me, text me. I will have my computer, but honestly, I'm getting ready to go to the airport to Chicago, but I will be working. It's not a vacation. So let me know if
Be
you need it.
safe.
Yeah, we're meeting. Oh, good question. How did you guys time out before everybody leave? Last semester, because I'm not familiar with this, how did you do exams? You did Zoom first?
Yeah, we would meet up on the tutor.com and then we would take our exam.
Yeah, let's do that. Just think, what if somebody, like, if I don't open Zoom, and what if ATI's website crashes or anything? So let's meet on Zoom at the usual time, and then we'll start the test.
Okay, I just wanted to make sure.
Yeah, that was a good question. Thank you. I didn't think about that. All righty. All right, well, have a good weekend. Good luck, and study, study, study. I'll see you next week.
Okay, be safe.
Thank you. You too. Bye-bye. Thank you. You guys are great. You guys are great. Thank you. Thank you. Good night, everybody. Have a good weekend.
You too.